Distal femoral fractures. Um, Regarding supracondylar region is defined by Muller et al. In 1990. It states that the supracondylar region is from the articular surface to 5 centimeter above the metaphyseal flare. It results in a rule of square, and the proximal distal segment of the long bone are defined by a square which sides on the same length as the widest part of the epiphysis. So the distal femur is trapezoid. Anterior part is 25% shorter than the posterior part. So we always need internal view radiograph to assess the screw length. If you draw a distal femur, the part is 25-degree inclined slope. Is the left side, the medial side is low in height than the lateral side. However, fracture is a coronal split fractures, most common lateral condyle fractures, increased risk of vascular injuries, low threshold to have vascular workup. Surgical fixation would be a list plate, locking plates, flex the knee to 20 degrees. A posterolateral approach is possible between the vastus and intramuscular septum, bicep and posterior sciatic nerve is risk. Perforated posterior aspect of vastus. Intermedial approach between the rectus femoris and vastus medialis is possible for intra-articular fracture that can't be reduced percutaneously. Medial approach between the vastus medialis and sartorius area distal to the massage intercondyle roof line must be avoided to avoid damage to cruciate ligaments. However, fracture needs AP headless screws or 2 screws for rotation control. Retrograde leaning supracondylar femur fractures more than 5 cm from the joint line. Diaphyseal femoral fracture in obese, pregnant, ipsilateral femur and tibia fractures, and periprosthetic fractures and bilateral fractures can go on for retrograde nail. Midline incision, medial parapatellar arthrotomy, flex the knee to 40 degrees, infrapatellar approach, transpatellar approach is also possible. Entry point in line with the axis of the medullary canal. Anterior to plummet side line and the roof of intercondylar notch. The entry point is anterior to plummet side line in excess of medullary canal. Cannulated drill to open the canal, ream the canal, put a large amount of nail, check the rotation, use long nail possible to prevent risk of peri-implant failure. DCS is possible and distal femur replacement is possible. Regarding the traction techniques, different types of techniques. These techniques are to reduce the pain, overcome deformity, and keep fracture aligned. Skin tractions, skeletal traction, and fixed tractions. Reduction principle used in the long axis of the limb, aligning the fracture that can be controlled with one that cannot be controlled. Reverse the mechanism that creates the forces. Skin traction applied over the large area of the skin, never more than 10 pounds or not more than 10% of the body weight. Contraindicating vascular impairment, open fracture, and marked shortening. Skeletal traction used in lower limb fractures and cervical rib fractures, cervical spine fractures, and fixation. Thomas splint fixed tractions are Thomas splint and Hamilton Russell splint. Quadricep rupture, renal failure, diabetes mellitus, rheumatoid arthritis, hyperparathyroidism, steroid injections, and fluoroquinolones. Always measure in Salvati index, which will be less than 0.8. Repair with transosseal sutures through the patella, non-absorbable sutures in the tendon, in the running, locking fashion. Crack or stitch can be applied. Repair the retinaculum with heavy absorbable sutures. So, retinaculum is sutured with absorbable sutures, while the tendon attached with non-absorbable sutures. Complication weak and knee extension and common complications.